just were in Japan. That's why. So it took us some time to land here. Thank you for having taken the time to be with us. I think we have a very exciting session. It has a quite funny title, Innovation Session Techniques We Have Never Seen Before. And I'm pleased to have our friends with us. And Stefan, Dr. Khalil Hamza from Tunisia, welcome. Khalil. And Iraqi.
Thank you for this kind of invitation to share this session. Thank you.
Jamal Langer is the president of the Tunisian Society, the Tunisian Group on Intervention in Tunisia. Mario Carminati from Milan. He didn't need the introduction. Mario, welcome. And Qais Batikh and Professor Lefroy from France. Professor Romaric Lefroy. Bienvenue.
Dijon.
Merci.
From
Thank
Dijon.
you.
And Dr. Qais Batikh from Djerba, Tunisia. Shak is supposed to be with us and to take the lead for this session, but I think he's stuck in the cath lab. And we have, I think, to maybe make some adjustment in the order. But I'm glad that we have Stefan with us. So he's the first speaker. And Stefan Bertog will be giving us a talk on radio frequency wire-based transeptal catheterization. Stefan.
Thank you. Thank you, Habib. Can you hear me okay?
Yes, very well.
Oh, wonderful. This is a great meeting, and I've seen the last two sessions, really great sessions. Let me try to share my screen, okay?
Sure.
One second. Can you see my screen?
Yes.
Yes.
Can you move? Yeah.
Wonderful. Okay.
Can you
I'm going to maximize it.
Full screen, Stefan, please. Yes.
There we go.
Yeah, good.
Perfect. Are you able to see it now?
Yes.
Wonderful. So, in terms of innovations, you asked me to talk about transeptal puncture with the radio frequency wire, which has been around for about a half a year at our institution. And to the background, though it's rare, transeptal puncture can have serious complications. All of us know that. And safer and more accurate transeptal puncture tools are desirable. One concern and source of complications is inadvertent injury to the left atrial wall via the transeptal needle. And this just illustrates some of the common problems. A very floppy intraatrial septum, especially if the left atrium is small, can have the risk of puncturing the opposite atrial wall, or you can have a very thick and leathery septum, as you can see here on this illustration, because of previous surgeries or previous septal manipulation, which can make crossing somewhat difficult. And that led to the use of radio frequency in the recent years. This is just an example of a frequently used catheter that's made by Baylis, which is a C1 catheter, which has a very similar configuration to the traditional BRK needle that all of us are familiar with. This needle, as an example, or this catheter, has a very blunt tip, which is in contradistinction to the sharp tip of the BRK needle. And once you cross the septum, will minimize risk of injury. I'm just showing this configuration for the radio frequency catheter, but it's very similar also to the use of the radio frequency wire. You have a generator shown on the left, the catheter or wire, which I will get into in a moment. You have the connector cable and the grounding pad. And this is just an example where use of this radio frequency catheter can be really helpful, which is an illustration of a very floppy intraatrial septum with a small left atrium, where you risk the injury of the opposite intraatrial wall. You can see here the puncture. This was with the RF catheter, was fairly safe, but with a sharp needle, you can imagine how you are prone to injuring the opposite wall. Now, shifting gear to the newer radio frequency wire. This is a wire which is an 035 wire, which is different from the wire that we use for advancing the typical SL1 or lamp sheets, which are 032 wires. So this is an 035 wire, which will not fit in most of the traditional sheaths or dilators. You can see the tip is blunt, just as with the radiofrequency catheter. And as it exits the dilator, for the first 2-3 millimeters, it's straight. Once you advance beyond that, it will assume the pigtail shape, which is, I think the diameter of it is 24 millimeters, and it becomes very soft, as you can see here. One of the advantages is that frequently when you lose capture with your transeptal catheter and dilator, and you slip underneath the fossa, most operators will probably take out the needle, put the 032 wire back up on the SVC, follow with the dilator and sheath, and then re-advance the needle. You can facilitate and shorten the steps with the radiofrequency wire. So if you lose capture and are underneath the fossa, you can simply just advance the radiofrequency wire, which will then assume its pigtail shape in the right atrium, and you can advance the pigtail back up into the SVC and follow with your dilator and sheath. Another really a nice feature, I think, is the sheath that comes along with it, and a dilator, which is made by the same company. And it's shapeable with a really good curve retention. And this is just illustrated here. Can you see the video playing? I hope you can see it playing, but
yes,
once you curve the sheath, it retains its shape very nicely. And remember, the wire is a very floppy wire at the tip, so you're not going to be likely to to take out the curvature of your sheath with that floppy wire. It comes with a snap fit mechanism where you snap in the dilator and the sheath, and as you can see here, the side arm and that little arrow aligned with the curvature of the sheath, just as it is with the BRK needle and the SL1 lamp catheters. This is the wire end. You can see that there's a radio-opaque marker which minimizes fluoro time. So as long as you are proximal to the hub of the dilator, you will not have exited the dilator with your wire, and you can thereby save your fluoroscopy time. This shows the clip-in mechanism here briefly. And then I wanted to point out this video because one thing you have to understand using this radio frequency wire is that once it exits the dilator, it's only straight for the first 2-3 millimeters, and then it assumes its pigtail shape, which means that if you focus on the right upper screen, if you just have it hanging out for 2 millimeters, you'll be straight. When you advance it a little bit further, it'll assume a J configuration. So if you have it out too far before trying to puncture and before applying radio frequency, you may slip off the septum. So it's really important that when you use this wire, you only have it sticking out at the most 2 millimeters from the tip to facilitate puncture. This just illustrates the floppy and atraumatic nature of the pigtail. And this is the back end of the wire. You just connect it to a cable, which then connects into the usual generator. This is the same generator that's used also for the Baylis transeptal catheter. And then this is another feature that I think is really helpful, which is that once you're across with your floppy pigtail tip, the rail becomes quite stiff. And so some operators use this for their mitral clips. I personally don't do this, to be honest with you. I still use the Safari extra small for mitral clips to deliver the big sheath, but I've seen some operators use even this wire to advance the large mitral clip sheath system. So it's got a pretty stiff rail once the floppy pigtail is in the left atrium. This just shows the configuration of the wire again and shows the sheath right next to it. And I'm going to show you how this works in a case. So this is a short sheath that's in the right femoral vein at this point. You just advance the J wire up into the SVC. Then you follow, you take the short sheath out, you follow with your Baylis sheath and dilator. You bring it all the way up into the SVC as you would normally with any other transeptal sheath and dilator. This shows this coming up with the Baylis transeptal sheath. And then you take the wire out and you advance your radio frequency wire into the dilator, and you bring it all the way up to the tip of the dilator and keep it short, maybe just 2-3 millimeters prior to exiting the tip of the dilator. And then you bring your system down just like you would ordinarily with any transeptal system. You take the whole system back until you reach the fossa as usual. This is shown here. And then once you're ready to puncture by TEE, once you have good tenting and good position of your system, then you can protrude the needle, the wire just for about 2-3 millimeters, and you activate the radio frequency and you can advance it into the left atrium. You can see again on the video here on the right hand side, it assumes a J-tip very quickly. Once you're across with a J-tip, you simply advance that J-tip, that pigtail configuration on your left atrium, and then you have a rail and you can exchange for whatever sheath that you desire to use. And so, in conclusion, the RF wire facilitates the procedure by reducing the number of the procedural steps. The atraumatic tip may improve procedural safety. Of course, nobody has demonstrated this in any systematic studies or publications. For people like me, I'm not like you guys. You guys do this a lot more frequently throughout the year. I'm not an experienced operator like you guys. So for me, using this kind of technology, either the radio frequency catheter or lately the radio frequency wire, I think it makes the punctural septum a lot more comfortable, and I feel a lot safer using the system. And so I can open up for discussion if there are any questions.
Stefan, thank you very much indeed. I joined a bit late, but can you use the radio frequency wire to perforate synthetic material? For example, the surgeons might use a tube.
Yeah, that's a good question. So first of all, I have not used that wire to do that, and my suspicion is that because of the immediate assumption of a J curve, once you exit the dilator, you're going to be likely to slip off whatever structure you're trying to puncture. And so if I had a situation where you have either a patch or a really leathery septum or a device that you're trying to puncture, I probably would use an RF catheter, which is a lot stiffer and which doesn't assume a J-tip immediately once it exits the dilator. So I don't think it would work for very stiff structures because slippage, of the structure. So, but maybe somebody hasn't. I'm not aware of it.
Thank you for this. Again, yeah. I have just a question about this new technique. Do you think that there is a high risk of the thrombotic formation? Because usually we are giving heparin after the septal puncture, but here maybe we have to do it before. Is there any difference about this? Any concern?
Yeah. So it's interesting. I mean, I typically give half dose heparin prior to the puncture, and then once I'm across and feel safe that it's in a good position, I would add the rest of the half of the dose. But I think any wire, of course, that enters the left atrium is potentially thrombogenic. But remember, this wire is in there only for a very brief period of time, and so once it crosses, once you're in the left atrium safely, you have created a rail, because remember the proximal portion of the wire is very stiff, so you've created a rail, and then you can advance any other system, any other sheath that you want to advance across it. So you're speaking, it's a matter of maybe a minute or two that you have that wire in place. If you're concerned about it, you can certainly administer full dose heparin. Personally, I haven't seen clot on it yet. I hope that remains like that, but you're right. Any structure, any wire that you cross the septum with, you're going to have a potentially thrombogenic surface and clots. And so you want to minimize the time. And of course, once you cross, immediately you should fully heparinize. Yeah.
Have you had a complication with this wire, such pericardial effusion, for instance?
Yes, I have not had a complication with this particular wire yet. Of course, with any other septal crossing system, I've had complications, including even the transseptal catheter. But the one thing that, again, and that's why I stressed it in the presentation, the one thing I would caution against is that when you're ready to apply radio frequency and to cross, I would really make sure that you don't have much wire protruding, because like you saw earlier, it assumes a J configuration very soon. And so if you have a J configuration, you're attached to the septum, you apply radiofrequency, not only can you slip off the septum, but maybe you can create, rather than a hole, maybe a small tear. So I think that's something I would be maybe cognizant of. But of course, I think any device ultimately can lead to complications, and so can this wire. But I haven't personally encountered any.
Okay, so I think we ought to move, because we've started late and we'll overrun things. So let's move on, and it's my pleasure to welcome once again Mario Carminati from Milan, access using transhepatic approach.
Okay,
Mario.
thank you very much, Jacques, and Abid, thank you so much for inviting me to take part of this outstanding meeting. I'd like to share my screen now. Can you see that now?
Not yet.
Okay.
Can you see my screen now?
No, just the video.
Nothing.
PowerPoint.
Nothing, just you.
Just
you.
me.
Try to share again.
Which is not good.
Yeah.
That's better.
I understand
It's coming.
you don't like me so much, actually, yes? Now you see my screen, correct?
Yes.
All right. So the topic I will cover is the transhepatic approach, which is an unusual access to the right heart catheterization. But in fact, we have a background, and the transhepatic approach has been used in the past for other uses as opposed to cardiac catheterization, like cholangiography, portal venous system hemodynamics, or to localize neuroendocrine tumors or embolysis varices, so non-cardiac uses. So what are the reasons for considering transhepatic approach for right heart catheterization? Basically, I'll list it here. Previous centralized or catheterization leading to occlusion of both femoral veins, or interrupted inferior vena cava in some situations like azygos continuation of IVC, or when you have as well obstructed or non-accessible of superior vena cava because of previous bidirectional gland or hemifontan, or in general for infections at site of access. So looking back at a large study published many years ago by Shiminan and published on circulation, you see that many patients have been catheterized with transhepatic approach. In this study, 42 patients has been reported from a wide range of age, starting from 1 day to 41 years. And many reasons for doing that, but most commonly, the reasons were bilateral femoral venous occlusion or bidirectional gland of hemifontan or interrupted inferior vena cava, as I mentioned earlier. And many successful interventions have been successfully performed with transhepatic approach with a very high success rate, up to 97%, like angioplasty or pulmonary, Fontan buffer, valvuloplasty, transseptal mitral, or some electrophysiological or ablations or something like this. So this is an example of a Fontan stent implantation in a stenotic Fontan pathway, followed by the transhepatic approach. Well, just to outline the basic steps, at least in our institution, to do transhepatic approach. We prefer to do the procedure in general anesthesia, use a 22 Chiba needle, starting from mid to anterior axillary position by using both fluoron and echo guidance. And the needle direction is towards the left shoulder, upwards and towards the left shoulder. Then when we inserted the Chiba needle, we remove the obturator and with gentle aspiration, until the blood is coming freely. We do some small gentle contrast injection to be sure we are in the hepatic vein, and then insert a coronary wire, as shown in an example that I'm showing you now, outlining the basic steps. Well, this patient had 16 years old with a clinical history of pulmonary atresia in septum and neonatal age. He had radiofrequency perforation of the pulmonary valve at 5 days of age. Then at 22 days, a modified BT shunt because of persistent cyanosis. And later on, at 2.5 years of age, he had surgical resection of right ventricular muscle bundles and bidirectional gland, establishing in that way an 1.5 ventricle circulation. And the patient did very well subsequently, reaching the age of 16 years with good clinical conditions, no cyanosis, etc. However, the echo assessment, besides showing satisfactory flow in cavopulmonary anastomosis, the echo showed a significant enlargement of right atrium and right ventricle and the large ASD with left to right shunt. That's the transesophageal pictures showing the large ASD with pure left to right shunt. And the goal was to transcatheter closure of atrial defect in this case, in this 1.5 ventricle repair. Obviously, after having done a balloon occlusion test of the defect. So we catheterized the patient. However, as you see here, we came across a bilateral occlusion of femoral veins. And in addition to that, of course, we had no access to the heart from the jugular vein because the patient had a previous gland anastomosis. That's why we decided to go ahead with transhepatic approach. This is a needle puncturing the hepatic vein and a coronary wire advancing to the heart and across the atrial septal defect to left atrium. A small injection of contrast starts to make sure we are in the right spot. You see the hepatic veins, IVC, right atrium, and the wire coming across the atrial septum and reaching the left upper pulmonary vein. After that, we advance a small end-hole catheter over the wire up to the left upper pulmonary vein, as you see here. Then we exchange the wire by advancing a stiff wire into this catheter in order to have good support to do the following procedure, which is the balloon sizing. You see the balloon sizing across the defect with the indentation there, but it's pretty large balloon. We measured that, and the maximum size was approximately 26 millimeter. And the temporary ASD occlusion was well tolerated, so we decided that it was a good idea to carry on and device occlusion of the ASD. So we exchanged the sizing balloon with a sheath. You see the sheath coming to the heart, to the left atrium over the wire, and then a 28 millimeter Amplatzer device, which is implanted here. As you see, the left disc, then the right disc implanted, and by both fluoroscopy and echocardiography, you see a nicely positioned device with complete occlusion of the defect. Well, this is a very important part of the procedure, so closure, the access. We prefer to use the vascular plug. Some others have been using coils or other stuff, other occlusion stuff. Somebody else is claiming that with a rather small sheath, that it is not a real necessary to put anything else. But personally, I'm quite afraid of bleeding, so I prefer to close the entry site with the vascular plug. Well, that's another patient, 5 years old, who had a transposition, who underwent arterial switch in the neonatal age. In the follow-up, with 5 years of age, there was evidence of right pulmonary artery stenosis. And again, at the catheterization, we came across a bilateral femoral vein occlusion. So we entered the femoral, not the femoral, but the hepatic veins with a transhepatic approach. Then the right pulmonary artery stenosis was confirmed by angiography, and very easy, we went ahead and implanted the stent in the right pulmonary arteries with very good result and no problem. So the transhepatic approach proved to be effective as a route for right-sided catheterization and can be performed with relatively safety. And this approach will allow therapeutic procedures that can be performed in any age of children, where other approaches can be impossible or more cumbersome or difficult. Of course, we can have complications. I think the most important possible complication is the peritoneal bleeding. And that's why a lot of care, in my opinion, must be taken to take care of the entry site and closing it safely. Then you can have pneumothorax or pleural effusion, but most of the times this is due to a technical mistake for a too high entry point. Of course, infection, portal vein thrombosis has been reported in the literature, but there are very, very uncommon. So when to use transhepatic approach in our experience? When you have bilateral femoral vein occlusion, and in addition, you have no access to superior cava vein due to previous gland anastomosis or superior cava vein occlusion that sometimes may occur with low-standing central venous line, etc. When you have access to the right internal jugular vein, in spite of the bilateral femoral venous approach, we don't use transhepatic approach, and we carry on with the neck approach in these cases. But in the cases we've done with transhepatic approach, all the procedures were very successful with no significant complications. So I will stop there. Thank you very much for your attention.
Thank you very much indeed, Mario. That
Yes.
was excellent
Yes.
example of cases.
I have a short comment.
Yes, yeah.
Yes, I'm an interventional radiologist. We are more familiar with this with axis, hepatic axis, and in general, the guidance we recommend to use sonography guidance up to cannulate the vein, introducing the guide wire. Then we can use fluoroscopy. We use in general both, and now with facility in cath lab to obtain in the same screen sonography and fluoroscopy. It's really a helpful tool. My second
may I reply to your comment, because for the sake of sparing time, I didn't mention that, but we routinely use the transhepatic approach,
yes,
together with our radiologist colleagues,
okay,
that are very familiar with, particularly, especially with the liver specialists that are familiar to do a echocardiographic assessment for doing liver biopsies. And we do that with both fluoro and echo monitoring. Yes.
Yes, close cooperation is always helpful. About the bleeding risk, in general, the axis of hepatic vein is not a high risk because the pressure is very low, and especially for the left hepatic vein. The left hepatic vein, there is a compression with the abdomen, and we are not obliged to embolize the tract. Maybe for the right side, the middle hepatic vein, with using large size and producer 9 French and 10 French for a large device, we are obliged to embolize. And in general, there is a very simple method. As resorbable embol as a gel foam is enough. we have experience now with the development of hepatic resection to use embolization of hepatic vein with retrograde fashion and anterograde fashion. And in general, the risk of bleeding is very low, especially when you use not large size introducer. And the more safer is to use the left hepatic vein. There is some increasing of radiation for hand operators, but we can use it, and it's really safe because the compression after we read round the sheet, the compression by the abdomen wall of the site of puncture.
Okay, I think we are quite a bit behind, so we must move. So thank you very much, Mario. And so the next talk is on mesenteric ischemia intervention. And Max Emor, yeah, there we are. Yeah, I can see you. Welcome, and all yours.
You, I don't know. I'm going to try to share my screen.
We can see it.
It should be okay. Yeah. Do you see it?
Yep, we can see.
I want to thank the organizer of the Pafcic. It's a meeting that I like very much. And I saw that this year it has a huge development with digital. I am aware that it's a technology that is really good for very far countries. I was asked by my friend Gamara to treat the current tools for mesenteric ischemia intervention. So it has to be remembered that mesenteric ischemia is a life-threatening emergency. Although in common, it has a mortality rate of 30 to 65%. So it's a very dangerous disease. It is interesting to consider that the diagnosis remains challenging today, even with all the technology we have. And we can say that only 22% of the patients that died was detected with ischemia. So it shows that there is still a room for improvement in diagnosis. The first thing that I want to say is that the current tools today have changed over the time and allows us to approach through femoral, brachial, or radial, and particularly radial, which is an important development. I don't have the time to go in details. Because I want to show you a very long case that is going to really show the techniques that we are using. The guide wires are exactly the same as difficult access, which are the Amplatz exchange guide wire or the Advantage. I want to show, I would say, the variety of what we are doing. We have an experience recent in the last 5 years of approximately more than 100 procedures, showing that the first vessel that was treated was the celiac trunk, followed by the superior mesenteric, exceptionally the inferior mesenteric artery. This slide shows you the variety of shapes that we are using in reality to access to the celiac trunk or the superior mesenteric, showing you that it's still a very difficult selective access, going from OK stick to a GR4 to an extra backup to a renal double curve 1 or 2, etc. Here is a summary of the different cases showing that we are using almost one guiding catheter per patient, but sometimes more. One important improvement has occurred in the last 3 or 4 years, which is the guiding catheter extension that allows you to go very far inside of the superior mesenteric artery or the celiac trunk and really to protect the placement of the stent, as well as using technique coming from the coronary, which is the microcatheters technique, and I will show you the case. In terms of guide wires, then again, you are obliged to use different guide wires from 0.18, 0.35 to 0.14 in some complex cases with very small artery to access, showing you all this variety shows you, in my opinion, the difficulties that we meet during the treatment of this patient. Most of the cases are performed in our center with 0.18, which is, we think, it's the ideal size of guide wire to access because it's less dangerous than 0.35, but it gives you enough support to land with a stent that could be 5 millimeter, 6 millimeter, even 8 millimeter, 0.14 inches guide wire doesn't give you the sufficient support. In terms of stent, we are still using mainly the Palma shots, but we are using that for Palmas for several years or over stent. So I go very quickly. Here is the case that I want to show you because it summarizes really very well the technique today. It's a patient with celiac trunk and SMA and stenosis. He is a 55 years old man. He is a patient with multivascular. He had a coronary PCI in the past, left carotid angioplasty, bilateral iliac and femoral angioplasty, and of course, all the risk factors. So this patient has developed an abdominal pain after any meal with a weight loss of more than 7 kilos. The abdominal CT shows a severe stenosis of the superior mesenteric artery and the celiac trunk. There is the baseline angio using what we do from the arm, which is 1.25 GR4. So you need this long catheter usually to access to the patient. So, and you see here that you have a stenosis of the celiac trunk, and you don't see very well the mesenteric artery because it's fed by collaterals. So I go further. So from that baseline result, we determine that there is a significant stenosis of the celiac trunk and occlusion of the SMA with retrograde collaterals from the celiac trunk. So we decided first to stent the celiac trunk to improve the flow to the mesenteric. So it consists into placement of a direct stenting of the celiac trunk with a Palmas of 6x18. And so it was not very difficult to place. There is the deployment of a stent that you see very well with the stenosis there marked. And here is the result showing in an overview that it was satisfactory. So I advance. As you see, we are using a guiding catheter in that case with a support. Excuse me, it goes for too much. We are using there, so with a support over 0.18 guide wire. So the second step, because of residual symptoms of the patient, was the treatment of the occlusion of the ostium. And in that case, we are using a retrograde technique, which is consisting into placing a guide wire inside of the celiac trunk. There it is. And if you see well, you have a recanalization, retrograde flow to the SMA. So from that position, we are going to advance an extension of guiding catheter, which is here placed. And we are going to try to go retrogradely to the ostium of the SMA. From that, we trap that guide wire. We are going to enlarge the ostium of that occluded SMA, and then again to use the antegrade approach. In that case, there is the antegrade approach. To place, you have the stent of the celiac, and through that way, we are going to enlarge and place progressively in antegrade. Voila, an antegrade 0.18 guide wire to stent that superior mesenteric artery. There is the dilatation over the 0.18. And here, after dilatation, we see very well that all the branches of the SMA are visible. And we are going to stent then again the superior mesenteric artery with a Palmas of 7x24. And here, the final results showing you that in the same session, the two arteries were treated using a mix of radiological technique and a mix of coronary technique. So we think that it's extremely important to know all these techniques because it's still something difficult, or I don't know what is approaching. So what I can say very quickly, that the diagnosis of mesenteric ischemia is still difficult. Always think about it, I say to the fellow. The endovascular approach is the first treatment to propose for mesenteric ischemia. And I think that the radial brachial approach today with long shift introducer, braided introducer, has simplified the challenging angioplasty. I didn't talk and show patients with thromboaspiration in acute cases, showing you that today, I mean, the armamentarium of the treatment of mesenteric ischemia is there. The problem is that we have to receive the patient earlier. Some of the patients arrive late, and when we arrive after 6 hours, usually there is a severe ischemia of the bowel and as well as the mesenteric, and we lose the patient because of the delay. So it works well when the emergency department recognize very quickly that disease and send you the patient very quickly. So this is my opinion, is really today to have a close cooperation between the emergency department and the centers able to perform this treatment. But the problem today is to receive this old patient. Most of the cases are old patients in time. If not, the death rate is still around 50%, which is extremely high. Thank you.
Thank you very much indeed, Max. This is fascinating. I've got to start learning about mesenteric arch branches now. Not something I've been doing or certainly keen to learn. Any questions or comments from?
Just a short comment.
Very short, yeah, because we're way behind.
First of all, about acute ischemia in general, we have all the tools for aspiration, but the problem is there is no imaging modality to show the ischemia. So we have in all cases to operate patient early to check and to assess the ischemia and the necrosis to avoid complications. And there is a third part of ischemia is no obstructive ischemia, well known by cardiac surgeons. It's an ischemia occurred in post-operative period after cardiac major cardiac intervention in patient with renal insufficiency, and this entity is now well known and treated by endovascular approach by perfusion of prostaglandin E1 that can save some patients less than 20%, but in general, it's really life-threatening complication. This no obstructive ischemia is really, especially in post-operative period after major cardiac interventions.
Yes, it's an excellent comment. The situation of ischemia after shock is really a problem. And then again, it's recognition. Most of the cases are biological with lactate, etc. recognition. So it is really a problem. And then again, the teams has to be aware that this complication could occur. It's not fully understood because it make a lot of pathology.
Just one short question, Max. Really nice presentation.
Let's make this last question because. Yeah, go ahead.
Those are osteal lesions usually. What is usually the instant restenosis rate in these after these interventions roughly?
I think it's around 5%, but really most of the case, this is why we try to have a general revascularization of a patient, because you could accept to have a restenosis of the superior mesenteric. Let's take the case that we did before. You could accept a restenosis of the superior mesenteric artery if the celiac trunk is present. So really, we act on the abdomen as the same time we do in coronary. It means we try to revascularize as much as we can in this patient. Of course, taking into account the contrast medium.
Right. Thank you very much indeed, Max. That's fascinating stuff. And we must move on with the program. Looks as if it's a pleasure to introduce myself. So let me see if I can show you. I'm going to try and be pretty quick. let me know when you can see the PowerPoint. Can you see that?
Yeah.
Yes.
Okay. So this is just a challenging case I thought I would show fairly quickly, and it's these are my disclosures. And the patient is a 19-year-old gentleman with 22q11 deletion, born with pulmonary atresia, VSD, and collaterals. I had multiple procedures previously. At the age of 15 months, he had a right Blaylock Pafcic shunt. At the age of 3.5 years, he had a Rastelli operation, and that involves patch closure of the VSD and a conduit between the right ventricle and pulmonary arteries. In his case, a 19mm pulmonary homograft was used, and there were some collaterals that were aortopulmonary collaterals that were unifocalized. Post-operatively, over the years, he remained well. At the age of 11 years, so almost 8 years after the Rastelli operation, he required ballooning of the right pulmonary artery stenosis and embolization of a right-sided aortopulmonary collateral artery with an ADO2 plug. During follow-up, he became breathless on exercise, and that was attributed to severe pulmonary regurgitation and right ventricular dilatation. Serial echoes, in fact, showed significant aneurysm in the right ventricular outflow tract, and I'll come to that. And the MRI scan confirmed this, and in addition, there was severe pulmonary regurgitation, increased end diastolic volume of the right ventricle index to 177 mils per meter squared, and this aneurysm that I mentioned, which measured 5 centimeters by 4 centimeters. The right ventricular outflow tract and pulmonary annulus dimensions were 25 by 31, and therefore that precluded or excluded the use of the currently available CE-marked percutaneous pulmonary valves, like the Sapien and the Melody. So we were trying to work out how to deal with this. Nowadays, we don't do 3D prints, but we work on simulation models. But at that time, we did a 3D print model of this heart from a gated MRI scan. And you can see here, this is the right ventricular outflow tract aneurysm, and there's the right ventricular outflow tract. And we use this for simulation testing. And the testing consisted of using an Amplatz muscular VSD device and delivering that at the mouth of the aneurysm, and at the same time testing a venous P valve because that is available above the diameters that the Sapien valve would have been used for. And the plan was really to, because if we closed the aneurysm, it would have been difficult to manipulate the venous valve around the outflow tract. If we use the venous valve, then it would have prevented access into the aneurysm. And so the other option, therefore, was surgery. And so on the simulator, you see here that the device was opened, the VSD device was opened and kept attached. And then the venous P valve was open. And as before fully deploying the venous P valve, the VSD device was released, and then the venous valve was released. And so this was the final result in the 3D print model. And this simulation, all done under fluoroscopy as well, showed the feasibility of this combination of procedures. So we decided to go ahead with this. We did 3D rotational angiography. We had access in both the right and left femoral veins, as well as right internal jugular vein. You see here the 3D rotational angiogram, and there's the big aneurysm in the right ventricular outflow tract. There it is on the transverse slice, but there you can see, and I'll come back to that. Having done the 3D rotational angiogram, we did the normal biplane angiograms, and that's confirming, firstly, free pulmonary regurgitation and the aneurysm as well on this AP cranial picture. The lateral shows the aneurysm, but is superimposed on the outflow tract. These were the measurements. The pulmonary artery measured 27 by 29 millimeters, distally approximately measured 27 by 25, and the right ventricular outflow tract length was 41 by 47 in the AP and the lateral projections. And so this really showed that what we were planning to do seemed to be the right thing, which was a combination of VSD device and venous P-valve. So during the procedure, we managed to access the aneurysm. You can see that with a pigtail catheter. And there's the aneurysm angiogram showing contrast leaking out and then filling the outflow tract. The aneurysm measured 8 millimeters by 15, the opening rather, measured 8 millimeters by 15 millimeters. And there's the aneurysm angio in different projections. Then we kept a wire looped in the right ventricular outflow tract aneurysm, and a second access catheter was passed into the left lower lobe pulmonary artery, and the third internal jugular venous access was a pigtail placed in the right ventricle for check angiograms. Having done that, we did some balloon sizing of the aneurysm mouth, and you can see that here, and that showed the diameter of 14 millimeters. There's the check angiogram of the balloon sizing of the right ventricular outflow tract, where it measured 27 by 23 millimeters. That just shows that there's very little contrast going past the balloon, and so various measurements were made. These were all to confirm really that a venous P-valve would be appropriate combined with the VSD. Through the right femoral vein sheath, we then changed to 26 French dry seal sheath and selected a 16 millimeter Amplatzer muscular VSD device because the balloon waist was 14, and selected a 30 by 30 millimeter venous P-valve because of the dimensions of the outflow tract. So we first positioned the valve delivery system into the left pulmonary artery origin over an 035 Lunderquist wire, which is positioned in the left lower lobe pulmonary artery. Then we passed an Amplatzer torque view sheath into the aneurysm from the left femoral vein over an Amplatz wire coiled in the aneurysm. From that, we then delivered an Amplatzer muscular VSD device, but kept it attached and not released it whilst keeping the delivery system in place. So you can see that there's the venous P-valve passing very easily into the outflow tract and left pulmonary artery. There's a wire coiled in the aneurysm. Now you can see the torque view sheath being passed alongside the venous P-valve into the aneurysm. There, the VSD, the left ventricular so-called disc, is opened in the aneurysm, and the waist in the waist and the rest of it in the right ventricular end. There you see the lateral projection, and notice the venous P-valve is still in place but not opened or exposed. There, the VSD device is now fully deployed but kept attached. And now we do some check angiograms on the venous P-valve, and then there we deploy the distal flare. Now, just to save, I was going to ask a question if anybody noticed anything else, but I'll save you time. You can see some contrast actually coming up in the ET tube, which is related to, as I'll show later on, notice the abnormal guide wire position here in the left lower lobe pulmonary artery. But with check angiograms, there's the contrast going up the ET tube as well in the bronchi. With the check angios, we open up the middle part of the venous P-valve. There's the aneurysm VSD device still attached. A little bit more of the venous P-valve is now exposed. And our plan was to fully release now the VSD device because the venous P-valve is about to be released, the proximal part. And so just to note about the fresh blood in the ET tube that the anesthetist mentioned as well. So that was something else that we would have to deal with. We made sure and checked that the aneurysm was still intact and not ruptured, obviously. But in any case, we were in control. And so once the VSD device had been released, we deployed the rest of the venous P-valve, and you can see that. And you see the pictures here of the venous P-valve right ventricular angiogram showing good position. of both the VSD device and the venous P-valve. And there's a pulmonary angiogram showing a competent pulmonary valve now. And again, to save time, obviously we now have to deal with the left lower lobe pulmonary artery. And you see here, we're sort of replacing the wire in a second with another catheter. And having positioned the catheter, there's a bit of a tear in that left lower lobe pulmonary artery. And so we placed a 9mm AVP2 plug, and that was followed by a 6mm AVP2 plug, and that stabilized everything. And so now there was no hemoptysis. There's the fluoroscopy at the end. There's the venous P-valve, Amplatz muscular VSD device, and a couple of vascular plugs sort of at the back there. And the patient was discharged home after 3 days. And then during follow-up, his effort tolerance improved. This is fluoroscopy at 6 months, showing good valve function, no fractures, slightly further expansion of the valve compared with at the time of release, and there's a bit of 3D reconstruction. And MRI follow-up, remember, there was end diastolic volume of 177, that's reduced to 102 mils per meter squared. Regurgitant, pulmonary regurgitant fraction was less than 10%. Right ventricular function had improved, and there was very small residual flow getting into the aneurysm. Mostly it was getting gradually there, gradually thrombosed off, and so that was a good result. So this is an unusual case, but model simulation helped in planning. Combined aneurysm and VSD device and delivering a venous P-valve was a good solution. And this way we selected the sequence, I think, was correct as well. I'll stop there. Thank you very much.
Very nice case. Jacques, can I ask you a question?
Yes, sure. Yeah.
Would you think that just implanting the venous P-valve, which is actually a cover stent, would that be enough, or you prefer to be safer to do what you did, in fact, both device and cover stent?
Yeah, so that's a good point. When we were simulating, it really had to, in order to cover the the aneurysm mouth, we had to deploy the venous P-valve much lower down, and that would have meant that it wouldn't have been too stable, and around it there would have still been a gap.
And the position would have been not perfect.
No, and then it would have been more difficult to deal with. So I think we were just trying to do it all in one go. Any other questions? Otherwise, we can move to Romaric Lofroy from France as well for catheter therapy of chronic venous insufficiency. Welcome to the webinar.
Okay, can you hear me?
Yeah,
perfect. Thank you very much to the organizers for the invitation. It's a great pleasure to be part of this. So let's talk about the new tools for chronic venous insufficiency, which is due in most of the cases to chronic venous obstruction. So we can talk about the compression syndrome, thrombotic or non-thrombotic at the early phase, which is called Meissner or Coquette syndrome, and which is responsible for post-thrombotic syndrome on the long term, which is a very frequent complication of lower longevity, up to 60% of patients within 2 years with some very uncomfortable clinical symptoms like pain and chronic edema of the leg. So now, over the last 5 years, recanalization of vents and large vents, proximal vents, has gained acceptance with very, very nice results and immediate results. Of course, we have to select the patients based on complaints and some scores like the Villalta score, which is the main one, and quality of life questionnaire. We mainly recanalize patients after 6 months at least after DVT, and it's always preferable to have preoperative imaging, duplex of course, but also cross-sectional imaging, we can choose between CT and MR to get information about stenosis, collaterals, everything. And the phlebography is the first step of the treatment, of course, and we mainly use IVUS during the treatment. So let me show you this example of iliofemoral on the left side, a chronic obstruction with a lot of collaterals, as you can see, by injection from the foot, in that case, on the leg foot. And on the right side, you can see some synesthesia here in the right common femoral vein, which is possible to see with MR imaging. And this kind of synesthesia can be very obstructive, even if we still see the flow. So in most cases, we use, my preferred approach is the popliteal vein every time it is patent. Otherwise, we can use a jugular approach or both, of course, according to the patency of the veins, but it's always preferable to use the popliteal vein because we are in the right flow and we have some support because the length of the different catheters is quite short. So the recanalization, of course, we have to do a careful evaluation of multiple collaterals and different projections. We can see here the main collateral. We use a long sheath 6 French to start, and then after for stenting, we use a 10 French sheath and a standard catheter, a 4 French glide vertebral catheter with stiff hydrophilic guideway is usually enough to recanalize, which is not very complicated. So for angioplasty, we use predilation with increasing balloon and stenting according to what we have to stent. We can stent the IVC or iliac veins, usually from the common iliac vein to the common femoral vein from 16, 14, and 12 in terms of diameter. We use nitinol stents all the time, of course. We now have on the market a lot of dedicated venous stents, sinus, venous, venovo, sinus obliquus. There is no comparative study, but they all work for this purpose. So we have to be careful with the proximal stent positioning. 2 options: to overflow and to put the first mesh of the stent into the IVC, or some dedicated stent now with angulated tip. I will show you some example. As you can see here, this is a normal stent in that case. So it's always preferable to put it very straight in the IVC to make sure that there is no overflow into the contralateral common iliac vein. And for the distal part, we can set below the inguinal ligament according to the best inflow, usually the femoral vein, sometimes it can be the profunda femoral vein. So we have to check this during phlebography to make sure that we put the stent in a landing zone which is healthy and which is the best inflow for a nice proximal flow into the different stents. So by popliteal approach, as you can see here on the left side, you can see some synesthesia into the common femoral vein and chronic occlusion of the proximal part with some collaterals, predilation, usually on the 0.35 guide wire, and then increasing dilation, predilation, and then extensive stenting from the IVC to the common to the femoral vein with large stents of decreasing size, which is something very easy to do. And this is the final result, as you can see here on this picture. So as I told you, we have dedicated devices now with angulated tip to avoid the overflow of the first mesh of the stent into the contralateral common iliac vein, which is called sinus obliquus from Optimed. Let me show you here in a prone position. This is on the left side, but the patient is in a prone position in that case. By popliteal approach, again, with a lot of collaterals, recanalization, predilation, and then predilation, as you can see here, with increasing size of balloons, and then deployment of the first stent, as you can see here, with angulated tip to avoid overflow, and then decreasing size of stenting up to the best inflow level, which is the femoral vein in that case. And this is the final result with a stent which is really in the common iliac vein and not in the IVC, to avoid any kind of thrombosis on the contralateral size. Of course, we always use IVUS before and after to see exactly the overlap between the stents, to see if there is no residual thrombosis, to make sure that we have the right diameter. The same for confluent stenting. We can sometimes perform reconstruction of the IVC with larger diameter, of course, up to the renal vein. Let me show you this example of, you can see the IVC here, and if we go down, there is a complete obstruction, chronic obstruction with a lot of collaterals on the abdominal wall, and with obstruction of both common iliac veins in that case, and re-injection at the common femoral level, as you can see here on both sides. So we decided by double common femoral approach in that case, double sheath, and you see the lumbar collaterals in that case, and then recanalization, like for arteries, with kissing predilation and angioplasty, and complete reconstruction of the IVC with a large stent in that case, and with a Tour Eiffel fashion for final result, as you can see here, with a very nice result. So it's always possible, even up to the renal veins, sometimes up to the subhepatic veins. This is also possible to do this in this kind of patient. So as I said, we use IVUS, very interesting for lesion diameter, length, to determine the healthy segment, and for post-stenting evaluation, of course, and residual thrombosis. It has been shown in the literature that this is very interesting, and IVUS can really change the treatment plan in a lot of patients. So this is not only a gadget, this is really very helpful and useful for this kind of patient. Let me show you this example of acute thrombosis on a chronic lesion on the right side after putting a filter in the IVC by jugular approach, the long sheath through the filter, and then aspiration with a thrombectomy device, Aspirex in that case, and then underlying lesion that we decided to treat with extensive stenting. As you can see here, this is the final result, and we can see some thrombosis here. It was not clear on the phlebography, so we can see with IVUS that this is really thrombus that we reaspirate in that case with the device, and then the final result after thrombectomy. So it can be very useful, especially when you have some overlap between two stents, and also for diameter of the vein, and to choose the best diameter for the stent. It can be very useful before stenting, of course. We usually put the patient on anticoagulant medication for 1 month, and then antiplatelet medication also for 1 month. This is not well clear from the literature, but this is something that we try to do in France in all centers, to do the same thing. And of course, compression stockings, very interesting. The patient can walk immediately after the procedure. This is the goal, to make sure that we have a very nice flow into the stents. Of course, the selection of patients is very important. If we look at the literature, the primary technical and clinical success are very high, because the stents are very large, with minimal complications and short hospital stay. We do this kind of procedure as an outpatient procedure now, and we published 2 times our results about that. We did something like 100 of patients over the last 5 years for this, and each works very well. The only thing is that if we have rethrombosis, early rethrombosis, we have to do aspiration very quickly, because on the long term, it is very, very difficult to recanalize instant rethrombosis in the veins, contrary to arteries. It is more difficult in veins than in arteries, because of the cast, which is very hard, but it works quite well. Thank you very much.
Thank you.
Thank you very much indeed, Romaric. This is excellent again, widening our interest. Quick question, and because otherwise we'll have to move on.
Just a short comment.
Go on.
You know, for chronic obstruction myotonia without complication. The result is very good, and we obtain more than 90% of patency. But with complicated patient with thrombosis of the lower limbs, chronic thrombosis, recanalization, we obtain less good results. And in general, some authors describe the use of arteriovenous fistula to maintain the patency in the system, and this fistula will be occluded by surgery or by intervention 1 or 2 years later. What do you think about this added to improve the patency of these complicated cases?
Yeah, very good comment. Honestly, the patency, even in thrombotic patients, is very, very high with very nice results. We never did any fistula. I remember one patient, it was a nightmare after for occlusion of the fistula with some complications. And honestly, it's a very rare and exceptional option. This is I mean, this is at least my experience. In most patients, we don't need this.
Okay, thank you very much. I think we must move because we're way behind, and it's my pleasure to welcome, I haven't seen him for a while, Farrell Hellig from South Africa, catheter-based management of coronary aneurysms. So Farrell, welcome. You're muted, Farrell.
Okay, you hear me now? Okay, hi Shaq, nice to see you. Thanks very much. No, we're late, so I'll rush. I'm talking about coiling of coronary aneurysms, and this is an area where there's not much data on the natural history of coronary angiograms, but I will just give you one slide of data and then show you some cases. The definition is 1.5 times the reference vessel diameter, and it's uncertain whether there's any benefit to treating coronary aneurysms of this dimension. But when they get to 2 times the reference vessel diameter, there's some data that there's a higher mortality associated with these aneurysms. Giant aneurysms are when they're more than 4 times the reference vessel diameter. In one definition, an alternate definition is 8 millimeters in children or 20 millimeters in adults. And these have a very high event rate of 50% at follow-up. And aneurysms can be fusiform when the longitudinal diameter is greater than the transverse diameter, or secular when the transverse diameter is greater than the longitudinal diameter. And they can be true where there's an entire vessel wall, or pseudoaneurysms where there are 2 or less layers of vessel wall in the aneurysm. So let me show you a case of a fusiform aneurysm. This is a method we've developed for treating these aneurysms, and we're busy working on our publication at the moment. This is a 56-year-old male with a positive stress ECG, normal LV, and this is a baseline angiogram which shows you this fusiform aneurysm in the circumflex. All of these cases needed stenting in any event because you can see there's a stenosis proximal to the aneurysm. After predilatation, this is placement of a stent from the proximal circumflex across the aneurysm into the distal landing zone. And this is following stenting, and you can see the aneurysm around the stent. This is the IVUS. These are just still images showing the stent opposed distal to the aneurysm, and then the body of the stent floating within your aneurysm on the picture on the right. So what we do next is we take a microcatheter across the aneurysm. You'll notice the guide wire is a little back, which it shouldn't be and you inflate a balloon across the aneurysm and inject into the aneurysm to confirm that we've got no flow into the artery, but only into the aneurysm. And then after that, we place some concerta coils. You can see in the right image, 7 millimeters by 30 centimeter coil and a 6 by 30 concerta coil into the aneurysm. And following that, you can see this picture showing the coiled aneurysm, and the IVUS picture of the right showing you the change in appearance of the IVUS with the coils around the stent. Just the very distal part is a little gap, and then you see this body of coils in the aneurysm and the patent lumen. And you can see as we get proximal, everything's fully opposed. And what the stent does, it prevents the coils from coming into the main vessel, holds them outside the stent, and the balloon up during deployment prevents the coils from coming into the vessel while deploying. So this is a much more complicated case. This is an aneurysm bifurcation in a patient with a normal LV and ischemia. What you can see here is on the left panel, there's a ruptured plaque in the left main, an aneurysm in the proximal LAD, and an osteal circ lesion and a CTO of the circumflex. The right coronary was normal. You see this aneurysm in the LAD in the right-hand panel in a cranial projection. So this is a dual injection demonstrating the distal anatomy for treatment of the CTO. And on the right-hand side, you see this aneurysm in more detail in this moving image involving the bifurcation of LAD and a large diagonal branch. So the CTO was first treated, and you can see this is following stenting of the CTO of the circumflex to ensure complete revascularization. Thereafter, a stent is placed in the ostium of the left main across the aneurysm into the LAD. And on the right-hand side, you see the picture after stenting. And then a pot in the left main and a kiss into the circumflex. And then you can see post-kissing the result on the left main. Then wiring of the aneurysm across the stent, you can see the challenge sometimes of wiring. You've got to get the wire curled up in the aneurysm to get enough support to deliver the microcatheter across the stent. So there you see this wire curling up in the aneurysm and the turnpike LP microcatheter going into the aneurysm. And now what's very important in the right-hand image is a tip injection into the aneurysm with a balloon occluding the LAD to check if the diagonal comes off the aneurysm or not before coiling. And here you can see that the diagonal does come off the aneurysm. We've got filling of the diagonal, but not filling of the LAD. Therefore, we cannot safely coil this aneurysm without risk of compromising the diagonal. So a tap technique is performed, stent across into the diagonal, and this required a ping pong technique because you needed two guiding catheters in order to have two balloons and a microcatheter. So there with the kissing, inflation, the coil is placed while both balloons are inflated in the LAD and diagonal. And then you can see in the right-hand panel deploying of the concerta coils. And then that's the result after deployment of the coils. You can see a small little residual aneurysm element proximally, but in this caudal projection it looks good. And then this is a relook at 3 months, and you can see, this is the final result, sorry. You can see that residual aneurysm proximally. Now at 3 months, you can see that we've got the patent artery and the circumflex remains patent, and we've got that little proximal area of aneurysm has now become occluded. And in the right-hand panel, you can see the OCT catheter in the diagonal. OCT is performed in the diagonal and the LAD. This is the OCT run, which shows good coverage of stent struts within the aneurysm. There are one or two uncovered struts as we come proximally, you'll see, but the majority of the stent is well endothelialized. There you see at about 5 o'clock, you'll see there's the bifurcation. Then at 5 o'clock, you'll see a couple of uncovered struts coming up. But over there, but really it's pretty good endothelialization of the stent following this procedure at 3 months. The last case is a pseudoaneurysm. This is a 17-year-old male who's had a previous bypass operation and a positive stress ECG. The symptoms, this is a rather complex angiogram, but what you can see here is the circumflex artery and this bypass graft, which was a jump graft across many branches, a diagonal graft, which was then jumped to all these lateral wall branches, which you can see in this graphic, covering 5 branches. The diagonal graft was occluded and the patient was ischemic, and here you can see in this Lima injection, this section of the diagonal graft which covers all these branches. This was heavily calcified, and multiple rotational atherectomy runs were performed with 2 burr stalls. And you can see in the right-hand image the retraction of the burr after a stall. And finally, after successful burring, the wire had, unfortunately, with all the movement, with this difficulty with ablation, gone into the small AV circ branch and created a perforation, which you can see here. The patient remained remarkably stable and didn't develop tapenade, presumably due to adhesions, and was discharged and came back a month later for an angiogram. And what you can see here now is more clarity on this jump section of the vein graft and the pseudoaneurysm. And this was wired, and OMs were treated first, and the left main was then stented into the circumflex. What you can see is the difficulty in wiring the outlet of the aneurysm, which required an angled supercross microcatheter to get into the correct branch. And then stenting across that branch, and the same principle with a balloon inflated coiling of the pseudoaneurysm. And this is the final picture, and you can see now filling of all these 5 lateral wall branches with this jump section, and the patients remained asymptomatic. So what I've shown you is a novel method for management of large coronary aneurysms utilizing readily available cath lab equipment with no side branch loss, which covered stents would give you, and a robust method demonstrated by follow-up imaging.
Farrell, thank you very much indeed. That's absolutely brilliant. I keep getting surprised whenever I attend these different webinars. I've learned huge amounts this afternoon as well, but we've overrun, sadly, because I was going to ask a few questions.
I just want to ask you about your case that you showed, if this could have been a method to put a microcatheter and then put coils instead of the...
Yeah. It would have required about 100 coils to, so that would have completely demolished our finances for a year or so. Habib, shall I leave your final comment to you, or?
Yes, thank you so much. Thank you. Thank you, Shak, and thanks to everyone for showing just unique techniques that indeed we have never seen before. Before closing, I just would like to answer the question that was asked by Hani Raghi from Egypt. I think he did ask the question, and the question was addressed to Stefan, whether you can ask it, Hani. Ask your question to...
Yeah, Hani, go ahead.
Yeah, it was just when we were talking about the radio frequency septostomy. I was wondering if you could deliver mitral dilatation balloons on this wire, like an Inouye balloon.
Yeah, remember it's an 035 wire, and yes, you can deliver any balloon over this wire. You may have to dilate yourself up. So if it's something good that you need to recreate, you use a smaller balloon at first. But any balloon that would go over another 035 wire will also track over this wire.
Okay. Another very quick question.
And remember, one advantage is that it's very stiff in the more proximal portion. So advancing a balloon across, should be pretty good.
I've spent my entire life till we actually finished most of the case of mitral stenosis, performing septostomies for mitral balloon valvuloplasties. And a couple of times early in my curve, I actually punctured into the aorta and not into the atrial septum. And one of the things which I have learned, I was actually taught how to do the septostomy by Inouye and Hung hands-on, was to put my pressure on the needle. And if I'm inside the aorta, I can see the aortic pressure. You know what? I just pull my needle out. It's like an intraarterial injection. Nothing happens. If you put a dilator in, you're done. You have to send the patient to surgery with the dilator in place. So perforating the septum with a wire, I lose this ability of getting the pressure on the other side. Have you ever had somebody, have you perforated into the aorta or had a beginner do that?
No, and I have had any complications with this particular wire. Again, we were talking about earlier for which cases I would use this wire. I wouldn't use it for cases where you have a difficult septum to cross. There I would probably use a catheter, RF catheter. I misunderstood what you said. So let me clarify one thing. You can put any balloon on this rail on the wire. It's no problem. However, if you're talking about doing a mitral valvuloplasty, which I understand, is that correct? What I would not recommend is to put this wire across the septum in the ventricle and then perform your balloon valvuloplasty, because it becomes very stiff, and I would be worried about tearing the septum.
Hani, just a final comment to add to your comment about puncturing into the aorta. I've actually, one of our EP guys did exactly that last couple of years. And instead of sending the patient to surgery, they asked us, and I put a plug across, because the dilator was into the aorta. So we kept it there, then changed over to an Amplatzer plug, and the patient was fine. The EP guys then punctured in the right place. Thank you very much to everybody. Habib, all yours.
Yes, thank you, Shaq. Thank you, everyone, for this very interesting and amazing session. We're going to London now with Jonathan Byrne and talking about coronary sinus reducer. Thank you very much.
Bye. Bye.
Bye.